The last session, but not very least, I would say, the trailblazers, the ideas for better tomorrow. I call upon on stage Ajit Nara, the academic director for Presidency Schools, to continue with this session.
Hi. So, my name is Ajit, and I work at the Presidency School in Nizamabad. You heard my wife Shravya earlier, so I don't have to repeat my story. And let me start with today's panel. An idea can change your life, right? We have an august group of people here, and who not only change a single life, but transform lives of the community around them. So from these set of people, we have 3 panelists who are doing a terrific job, and they are ideators who are making a difference. So let me call Dr. Padmanabha Reddy from NICE Foundation. NICE Foundation works in the maternal and the neonatal health sector. They have the Institute of Newborns, which is one of the best neonatal centers in India. And they're also into tribal reproductive child health. And they also have a program which I really don't like, but it's called School Healthcare. So the slogan is, if you are sick, come to school. Next, we have Nitya Kanuri. Nitya is a researcher from Stanford, and she has a program called Manamali, which means the gardener of the mind. And they are involved in mental health, and they're using technology to identify and solve problems of mental health. And finally, we have Govinda Upadhyay. He is the CEO of LED Safari. They are trying to simplify solar lamp technology, and they're trying to bring it into everyone's house. So welcome, and thank you for coming. And the first question I have is for Dr. Reddy. And Dr. Reddy has been working in this sector where there is very little room for error. We are dealing with very small children and infants, and every life counts. So how does an idea in this sector work? And what are the problems that you face in this sector? And is there any idea that you have that can really help this sector?
Good evening, everybody. I know we are the last panel of the evening. I will try to be brief and try to explain what we are doing. Before I do that, we need to understand the healthcare scenario of our country. So when you look at it, India is a country of numbers. We have 1.27 billion people to be taken care of. We constitute 17.5% of global population. That is to say, every almost 5th or 6th person on the planet is from India. And India is a country where the GDP expenditure on health is less than 1%. So when you compare with the US GDP, which is 17.5%, and then all developed countries spend double-digit GDP on healthcare. So there is, given that, we have very poor public health infrastructure. Even to date, as you know, we are battling with sanitation and safe drinking water issues in most of the country populations. And then primary care, most of the public health facilities, PHCs, are not equipped well, not equipped in terms of human resources. There's a lot more to do in that segment. Then coming to the urban and rural divide, 70% of India's population is in the urban settings, and 80% of the doctors are in the 80% of the doctors are in the urban setting, and 70% of the population is in the rural setting. That's a mismatch. So if you want to have care in the rural region, which is where our population is, we don't have doctors. And then Genetically, India, we as Indians are prone to certain non-communicable diseases, lifestyle diseases otherwise called. We are being called vulgarly as the diabetic capital of the world, and then the hypertensive capital of the world. And then we have a lot more load of renal disease and renal failure as a burden in the country. Given all this, 70% of our healthcare expenditure is out of pocket. Insurance reach is not there. Even to date, it is in the single digit format. So this has to change. This is the background wherein if you have to do something for health in our country, we need to look at this as a perspective. NICE Foundation, what is NICE? NICE is an acronym, Neonatal Intensive Care and Emergencies. I'm a neonatologist, so my perspective was how to save a newborn life. That was what it was. Way back in 15 years back, I had a plan of creating an institute for newborn in our country. As you know, every fifth baby born on the planet is born in India. And then every fifth baby dying on the planet also is from India. Given that, we never had an institute for newborn in the country. We have institutes for kidney, heart, liver, cancer, everything, but we never had an institute for newborn. With this idea, I came out with a proposal wherein how can we deliver world-class care to a problem newborn at Indian cost, where an Indian parent can afford the care. In the Western world, if you have a problem newborn, it's called a $1 million baby. That much is the expenditure you need to spend to get the baby out of the hospital. So how do we address that issue? With this proposal, I went to meet the father of our organization, the chairman of our organization, Dr. Kalla Manjireddy Garu. He was the chairman of Reddy Laboratories. I went to him and told him about the need of creating an institution. And then within 3 minutes of my interacting with him, he came forward and then said, Dr. Padmanabh, I will do everything possible to see that this institution comes up. With that support and vision of his, we created the largest neonatal institute in the country, 80-bedded NICU in Hyderabad, which is on a public-private partnership model with the state government of Andhra Pradesh, wherein the capex burden and the profit is not in the bill. So to say, we are able to reduce the cost of care by 50 to 60% of the market, with quality comparable to international standards. When we reviewed certain cases, similar cases from the Western world institutes, our cost of care is 1/100th the cost of the Western world. That is what we have achieved out of the Institute of Newborn, which is in Hyderabad. Then coming to the models, NICE is an organization, we create templates. India is a country of numbers, as has been told. Our ex-finance minister, Chidambaram Garu, one time in a conference mentioned, we put our money into proven failure models. So most of the healthcare models in our country are proven failure models. So we wanted to create templates wherein come out with an idea, implement it in the field, prove the point, and ask the stakeholders to take it further. So in that context, we have an urban model of creating the Institute for Newborn. Then we have the rural and the tribal population where we do reproductive and child health as a priority, and then the primary care. The regions we work are the tribal regions, primitive tribal regions. We are in Araku Paderu in Visakhapatnam. We are in Mahbub Nagar, Amrabad and Achampet, Kolhapur regions, where we do complete antenatal care and then perinatal care and newborn care. We do field level research. We have recently concluded a randomized control trial wherein we did the service arm and then the London school did the research arm. And then the assumption was by creating health awareness to an expectant woman, tracking the at-risk mother to the nearest healthcare facility, we said that we will be able to reduce the neonatal mortality by 25% in 5 years. We achieved this within 3 years. And then looking at that model, now the funding agency has asked us to do in all the 464 villages, which we are doing in Mahbubnagar district now. This is the institute which is in Hyderabad, wherein what is available in UK, US, university hospitals, technology is available. We do total parental nutrition, we do high-frequency oscillatory ventilation, we do conventional ventilation. What is required for a critical newborn, a 600 grammer, what he needs is being provided in this institute. And then this is the model, the rural antenatal care which is going on, wherein 2 times in a month a fixed day service happens in the village, and then antenatal care is provided, and women who are at risk are tracked and then moved to safer place of delivery. One important aspect which we do is the participatory discussion group activity with the tribals. You can see the Lambadas and the Chenchus, wherein we improve their knowledge of healthcare, antenatal care, and then what is to be taken care during antenatal period in terms of nutrition, general health, danger signs, and when to move to the healthcare facility. This is the other model called the CHIP model. This is a model where we have started 2.5 years back with the CSR support of Dr. Reddy's laboratories. Now we are doing around 200 villages in 3 different regions. We are in Srikakulam, Vijayanagaram, and Nalgonda districts, wherein doorstep healthcare is provided to everybody in the village. Means to say, every alternate day, a midwife runs the clinic in the village, examines all the expectant women, takes care of the children, and then elderly. In most of the villages, we see that a lot of older age population which has diabetes and hypertension who are not being taken care. Through this model, we are delivering doorstep care in the villages. This is the other model where we do the school children's healthcare program. As Ajit was mentioning, we have a model called School Child Healthcare Program, wherein a government school accessing child, we do everything from common cold to cardiac surgery at no cost to the family. This is costing us around 1 cent a day. We are doing this for the last 11 years, and then incidentally, this has been the model which has been taken up as a model for the country in the 11th 5-year plan. So that was the intention of doing templates which will be useful in our country. As you all know, the poorest of the poor access the government schools in our country. Education is a birthright, so is midday meal. We said health should also become the birthright. That is where the tripod of support for these poor children. Then we talk about the scalability. Every model of our model, we see that it is a replicable model. India is a country of numbers. India is a country of different regions and expectations. So our models are all the time replicable with a bit of tweaking. And then we also come out with a plan wherein over a period of time, we make the project sustainable. We make the community participate in contributing to the program, and then the civil society also supporting to it. And then eventually government pitches in and then takes the program further. Then all our programs are planned in a manner to be implemented in minimum time. At the same time, it should be a cost-effective program, and then it should also reflect in terms of impact as much as possible. Thank you.
Thank you, Dr. Reddy. I'm very happy that we've had you on stage and the kind of work you're doing. There was one more organization called Save the Mother, who's doing something very similar in the UP, in the Uttar Pradesh state. And we hope that there'll be some sort of collaboration where there's some sort of knowledge transfer, because we've already done it, and so both organizations will benefit from it. That said, mental health is another issue that is not often talked about. And we've had, since we are in a school, we have a lot of kids that sometimes we identify that require some sort of medical help or intervention regarding their mental health. And parents, for some reason, don't go to the doctor because, and they let the kids suffer because there's a lot of stigma associated with the whole issue of mental health. And we have Nitya here, who is currently working on the problem. So Nitya, does a mixture of technology and medicine help this issue, or is there any idea that you have that can change the scenario?
Yeah, thank you, Ajit, and thank you to everyone at KS for having me here and allowing me to chat with you today. So I am a researcher at the Behavioral Medicine Lab at Stanford, and I'm going to talk to you for just a few minutes about some of the research that we've been doing here in India over the last 2 years. So I would like to start by just paying tribute to all the different people that have enabled this project to be possible. We have a lot of researchers across the states, across India, NGOs within India, at NIMHANS, groups in Goa called Sangith, who have all really gathered together to see, can we do some research around how to make mental health care more accessible in India? So this is a look at some of the people who have contributed to this project and who I'm going to try and be an adequate microphone for today. So why did we start this project? The WHO has said that 1 in 4 people in the world will struggle with some form of mental distress in their lifetime. So we know this is an issue globally, but in my opinion, I don't think there's a lot of research being done in India to address this issue. And we know there's an issue of, I don't know how to go back, of treatment gap. So if you take a look at these numbers, you can see that in the US, we have about 550,000 mental health care professionals. And for a population 4 times that size in India, we have 5,000. So this bears the question, how do we address this treatment gap, and what types of innovations might be necessary to take on this kind of challenge? And in my opinion, I think research is necessary to really begin to answer these questions. So technology might be a way to more innovatively try and tackle this. So we know that mobile access is rising around the world, and there might be new ways to deliver treatment if we can figure out some of the feasibility issues. This is just a quick look at some of the groups in India trying to tackle this issue. So you have platforms like ePsych Clinic that's just trying to connect licensed professionals to people in need of mental health care. You have groups like Your Dost, which is basically saying, hey, everyone could benefit from mental health care, and a lot of people in the community could be your dost, your friend. So you can actually go to this platform right now and chat with someone live. There's Healthy Minds doing similar things. But the biggest issue for a lot of these startups is raising funding and demonstrating there's a need and there's a market. And this is also White Swan Foundation. It's a group trying to tackle the issue of mental health and the stigma around mental health using knowledge and awareness. But again, the issue is, can we point at something and say, hey, here's a clear need for more services in this area, and here's a clear pilot trial demonstrating this could be a feasible route to do it. So we've partnered with the Birla Institute of Technology and Science over the last 1.5 years to really begin to explore how might we do 2 things. So I'm really grateful to BITS and to Raju Reddy, who was actually the connect to BITS 2 years back, for basically giving us our own sandbox to begin tackling these issues. So 1, how do we change culture around mental health? Why is there so much stigma? Is it coming from individuals? Is it coming from caretakers? Is it coming from the community? And 2, how might we begin to connect individuals in need of care to services they find more comfortable, more accessible? So on the first level of community awareness and tackling stigma and understanding mental health perception, we had to first raise awareness. So at the BITS campus in Hyderabad, we gave lectures to students in classrooms, in the mess, in hostels, literally anywhere on campus. They would let me talk to students and just engage them in a discussion about, what does mental health mean to you? How do you take care of your physical health? And on the flip side, how do you take care of your mental health? Did you know that the word health is in there in mental health? Then 2 is about empowering the community to take hold of this conversation around mental health care on their own. So I think a lot of people in this room have been speaking about sustainability and not assuming you have some kind of offering to give, but empowering them to both identify the problem and tackle it themselves. So we created student teams across all of these campuses to take ownership over the conversation around mental health, to ask Mime Club to put on a play about mental health, to wear t-shirts like this that say, I'm a Manamali mental health ambassador. If you have questions, come talk to me. Have peers serve as liaisons to help connect individuals who might need care to the on-campus counselor. We also had events around each campus. So this is some photos from some of our student-led events on the 4 BITS campuses in Goa, Dubai, Hyderabad, and Palani campus. So you can see that students hosted a run to bring awareness for the connection between your mental and your physical health. There's students who held a sticker campaign in which they asked everyone on campus to wear a sticker and write, "What makes you anxious?" to really bring about, in a fun way, attention to the fact that we all go through different levels of stress. It's normal. And you have different online challenges. We tried to attack students wherever they might be. So social media, how do we get students conversing about mental health? We have a campaign being rolled out right now where some of the prominent members of the BITS alumni community have lent their faces for a campaign about mental health awareness and help seeking and how to lend a hand to a peer. Basically, we've just been piloting different ways of sparking communication. So that's tactic number one. Part number two is about how we might offer services to students in a way that is more accessible to them. So this is an example of the online and mobile-based program that our team has developed and has been delivering to students at the BITS Pilani schools over the last year and a half. So the way this would work is everyone on campus would take an online anonymous survey in which they would answer questions about their mental health and wellness. And based on the way they answer these questions, we would deem those eligible to access an online program to help them deal with their mental distress, specifically their anxiety. If they said yes, they would connect to this online program and they would get access to it for 3 months. And in addition, they would have access to an online mental health counselor somewhere in India who could communicate with them via telephone or via messaging in their online program. And the rationale for this is a lot of students won't seek help for many reasons, but a lot of them are stigma related. So they may not want to walk to the counselor's office on campus for fear of students seeing them. You know, oftentimes the counselor's only there for 4 hours out of a week, and they can't skip class. They don't want parents to know. They don't want professors to know that they've walked into this office. So we're not trying to say you should shy away from accessing care. We're just trying to say, if we offer care in more ways, might we be able to get someone to say, yes, I would like help sooner rather than later. So this is a look at the mobile app version. So basically, it's broken. What you would do in normal therapy, let's say an hour per day for 12 weeks, once a week, is broken down into a 10-minute session that you would do every day, in which you would check in, you would learn something about mental health, and then you would learn a technique to help address it. And we found that students, and even adults and other populations we've done this with, find this a little bit more palatable. It's a little bit easier to take this first step when it's not, you know, overcome the barrier of walking and signing up for a counseling session. And I think to speak to a little bit about the rationale behind this approach, I think technology can potentially address some of the issues of healthcare service delivery. So at a macro level, I think platforms like this can enable more efficient delivery of mental health care. So for example, we could improve the reach. Students who are in areas that might not have the ability to have a counselor come to campus, let's say in a remote region, could connect with someone online. We could improve the scalability. So once you figure out the mechanisms of delivering this, this could be replicated quite easily. It could potentially be more cost effective by allowing those limited resources, those 5,000 mental health care professionals, to limit their time and interaction with students to that human touch component, and instead programatizing the content that should be standardized for everyone, you allow them to use their time more efficiently. And lastly, I'd like to say there's one point that I'm going to call labor efficiency. So in addition to leveraging those trained specialists to optimize their time, I think there's even opportunity to create jobs for people who are maybe unlicensed but practicing mental health care clinicians in India. To support this type of work, to be an online counselor, there might be different criteria. And you know, these rules and protocols will be determined country by country, but I think stepping back, we just want to say, might there be a different way to think about mental health care service delivery in different contexts? And that being said, I will put one caveat in there. I don't think anyone should think we should go from traditional one-to-one mental health care to 100% technology, get rid of humans. I think you'd be setting yourself up for failure. Everything should start with a proper needs assessment, with understanding what the community wants and understanding what's possible in given the infrastructure and resources available in a place like a university, or if you want to extend it into an early workforce or into a smaller community.